Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome everyone to this CardioNerds episode on long-term management of atrial fibrillation. I am Kelly Arps. I'm an electrophysiologist at the University of Michigan and one of the series co-chairs for the Atrial Fibrillation series. Our episode lead is Dr. Elizabeth Davis, who's a cardiology fellow at the University of Texas Medical Branch in Galveston. Also present today is my co-chair, Dr. Naima Maqsood, who is a current EP fellow at Temple University Hospital.
Thanks, Kelly. Let me introduce our faculty expert for our listeners. We are excited to learn from atrial fibrillation treatment enthusiast, Dr. Edmond Cronin. Dr. Cronin is an associate professor of medicine and an electrophysiologist at the Temple University Hospital in Philadelphia. After completing his medical training and cardiology training in Ireland, Dr. Cronin pursued EP fellowship at the Cleveland Clinic. He has authored several key publications, including his recent contributions as part of the Guideline Writing Committee for the 2023 ACC/AHA HRS Guidelines for the Diagnosis and Management of Atrial Fibrillation. Not only is he an expert on AFib, his professional interests also include VT and cardiac implantable electronic devices. He's a great evidence-based clinician, proceduralist, mentor, and educator. Thank you so much for being with us today, Dr. Cronin.
Thanks so much, Naima. Happy to be here.
Dr. Cronin, before we get into the podcast, I have to know, being so accomplished, do you find free time during the day? And how do you like to spend that time?
I don't know that I'm so accomplished that I don't have free time, but I think like all of us, especially in medicine, I think it's very challenging. Often, our jobs consume any time that they can, so it can be quite challenging to find time to do other things like I think everyone finds, but I think it is also quite important to do so. So I try to, maintain family time, and my kind of interests that I spend some time on are running and photography. Those are two things I think that I kind of indulge myself in.
Those sound really awesome. I live on a beautiful beach town. I certainly hope to get further into photography at some point, in fellowship when I'm less busy. So let's get down into it. We'll dive into the discussion on long-term management of AFib. 2023 guideline seems like quite the endeavor. What do you think is the most important change in that guideline compared to the prior?
Yeah, I think there were some very well-awaited or long-awaited and timely changes in recommendations for catheter ablation. First of all, there's a class 1 indication for catheter ablation as first-line therapy in selected patients. I think that was appropriate, and that's a change. Especially, there's a related class 1 indication for catheter ablation of AFib in appropriate patients with heart failure with reduced ejection fraction. I think that's a significant statement, and I think, again, it was appropriate, and would say that, wouldn't I? But I think it was appropriate given the evidence basis behind it. I like the way there's a kind of a diagram there that kind of helps people to figure out who are the appropriate patients and who are most likely to do well with ablation of AFib and heart failure and who are less likely to do well. I think that's very important because when you hear about catheter ablation of AFib in heart failure patients, obviously that's a significant undertaking. There's some risk involved. There's some risk of hemodynamic decompensation, volume overload, etc. Nobody is saying that you should do this in everybody. And the patients enrolled in the trials, would have had certain characteristics, maybe certain exclusion criteria were applied, et cetera. So I think it's important to kind of have a reference there to look at and compare with the patient in front of you and think, is this someone who's likely to do well with catheter ablation, or is this someone who's, not so suited maybe to it? So those were probably some of the big changes. I think some other changes that were novel and interesting was the concept of stages of atrial fibrillation. So that was more like a concept that was introduced to recognize the fact that atrial fibrillation is a very kind of diverse condition with lots of manifestations and lots of different patients in whom it's kind of the endpoint of various different processes, and to emphasize the fact that I feel like it is kind of a continuum where you can pick up pre-AFib condition long before the patient ever develops atrial fibrillation and use that as a stimulus to implement more lifestyle changes and address risk factors, et cetera, before perhaps they actually present with atrial fibrillation.
Thank you so much for those great insights, Dr. Cronin. We really appreciate having your input as a guideline author. Atrial fibrillation, as you mentioned, the management for that can be quite nuanced. So let's assume that you are in the CardioNerds EP clinic and you are about to see a new patient, Ms. Palmona Vina, She is a 64-year-old African-American woman with a history of persistent AFib, heart failure with preserved ejection fraction, obesity, her BMI is about 27, and hypertension. She presents to established care with you in the clinic. For her AFib, she's currently on metoprolol succinate 25 milligrams daily and apixaban 5 milligrams twice a day. She was diagnosed with AFib a year ago and underwent direct current cardioversion with success. However, her AFib returned about 6 months ago. She had mainly been seeing her primary care doctor in the interim. Records from the primary care doctor today show that all recent EKGs have atrial fibrillation. EKG in the office again also shows AFib with a ventricular rate of 95 beats per minute. Dr. Cronin, how would you classify this patient's atrial fibrillation, and how does one determine which class a patient is in?
Sure. So I think she's got persistent atrial fibrillation, and that implies atrial fibrillation that just the patient goes into and they stay in it until we do something about it. That's how I think of it. The classifications of AFib are very important to describe the kind of presentation the patient may have, and then also how to go about managing them, because it is a little different from one to the other. And it's quite simple, like paroxysmal atrial fibrillation is just AFib that starts by itself and it stops by itself. The episodes usually last hours to maybe a day or two. There's a relatively arbitrary time cutoff of 7 days in the definition for paroxysmal AFib, but the vast majority of patients that last for hours or a day or two at most, and it stops by itself. In other words, they come out of AFib without the use of a cardioversion or without ablation or without any drug therapy. That is, they come out of those individual episodes of AFib. And then persistent AFib is where the patient goes into AFib and they stay in it until we do something about it, like a cardioversion. And that's, I think, a basic and an important classification difference. You very often hear, in a case presentation, oh, this is someone with paroxysmal AFib status post cardioversion. I always pull people up at that stage and say, hang on a minute. It's not that people with paroxysmal AFib can never have cardioversion. Sometimes it is appropriate. Sometimes it does occur, but it's almost an inherent contradiction. If they have paroxysmal AFib, they're unlikely to have had cardioversions apart from occasional exceptions. So just think about what you're saying and avoid contradicting yourself in one sentence. The long-standing persistent AFib then is AFib that has been present for more than 1 year continuously. And that's a little arbitrary as well, but there are abundant lines of evidence that tell us that AFib begets AFib and that it becomes harder to get someone out of it the longer they've been in it. And the 1 year cutoff is a reasonable cutoff to distinguish AFib that becomes more difficult to get out of or to maintain sinus rhythm versus AFib that's a little easier to treat or easier to get the patient into sinus rhythm. So that's long-standing persistent AFib. So just persistent, but for at least a year continuous. And then we have the category of permanent AFib. And this used to mean years ago, AFib that was present for more than 1 year, but we've changed the definition many years ago to say that permanent AFib is now where the patient and the physician in conjunction with each other have decided to accept AFib as the chronic rhythm and not to try to restore sinus rhythm, so not to pursue rate control. So it's a decision, a joint decision between the patient and physician to leave it alone and to use rate control as a strategy and not to pursue sinus rhythm. We call that permanent AFib. Another term that you hear is chronic AFib, and that has been abandoned many years ago. I encourage people not to use that. It's ambivalent and confusing because it could mean, you could have paroxysmal AFib for 5 years. Say, for instance, you're in and out of AFib over the course of 5 years. That's a chronic condition, but most people used chronic atrial fibrillation to mean persistent or permanent atrial fibrillation, meaning that they were in the rhythm chronically, but it's confusing. So that term has been abandoned, recognizing that all AFib is, or almost all AFib is a chronic condition. So we don't use the term chronic AFib anymore.
Thank you so much for clarifying not only the definitions, but the relevance of assigning those definitions appropriately to patients. It sounds like we can definitely put our patient into the persistent atrial fibrillation category. So now, speaking with this patient more, you start to address an issue that we run into a lot, which is trying to define whether patients are symptomatic of their AFib and what their associated symptoms are. I know that's been a challenge for a lot of my patients. This patient, Miss Vina, reports daily palpitations that don't bother her much. However, she does say that she has increased fatigue with exertion and often thinks her palpitations are more severe on exertion. In your experience, what are the most common symptoms of atrial fibrillation that people report, and what's the best way to separate AFib symptoms from other common comorbidities like heart failure or lung disease?
Yeah, palpitations are certainly a prominent symptom of AFib, and paroxysmal patients, they're usually the kind of most prominent symptom, but they're not the only symptom by any means. And actually in persistent AFib, if you look at the data that's out there on symptoms in patients with AFib, In persistent AFib, palpitations actually fall into second place behind things like shortness of breath, etc. And there's this category called exercise intolerance, which doesn't tend to be asked in symptom questionnaires, etc. But I think that's a useful term or useful concept, that the patient just can't do what they used to be able to do anymore, or they can't do it as quickly. So they may not complain and say, well, I'm short of breath or I have palpitations, but they may just say, oh, I used to be able to walk to the end of my drive, collect the mail and walk back, and now I have to stop halfway. And what makes you stop? Well, I don't know. It can be hard to tease out, but they can't do what they should be able to do or used to be able to do when they were in sinus rhythm. And I think you have to be careful not to just think of AFib in terms of palpitations only. It causes palpitations, it causes fatigue for sure, very prominently in some people. Some people will report they just can't do anything when they're in AFib. They just have to stay at home and just not do anything, wait for it to pass. It just drains them of energy. Shortness of breath is certainly causes this concept of exercise intolerance. And there are a few other less common things that I've noticed over time, such as orthostatic hypotension. It tends to make that worse. Some people are orthostatic only when they're in AFib, but when they're in sinus, they're not. A couple of other weird and wonderful things like that. Increased urination in occasional patients, which is a well-described but little known symptom as well of many tachyarrhythmias. So I think just speaks to the value of talking to the patient, asking non-leading questions, open questions, not focusing orally on palpitations, and being open to these concepts of fatigue and exercise intolerance and shortness of breath and other symptoms like that too.
Really appreciate that insight, Dr. Cronin. I know I have seen a lot of people go in and ask about palpitations, and the patient says, I have no palpitations. And that's like the end of the questioning as far as this being an arrhythmia. So I'll definitely make sure to keep in mind for myself, but also my learners, that point that AFib is more than just palpitations. So going back to our patient, after further questioning, we are able to establish that Miss Vina is quite symptomatic from her atrial fibrillation, as she only remembers feeling well for those 6 months right after the initial cardioversion when she was persistently in normal sinus rhythm. We counsel her that the maintenance of normal sinus rhythm is likely to help with these symptoms again. Miss Vina, though, is nervous about repeat electrical cardioversion as she doesn't feel like the first one really worked for her since she ended up back in AFib. How would you advise this patient regarding the need for rhythm control and other available options?
Yeah, I suppose I would talk to her about the East AF trial in particular, because it probably applies to her, as long as her AFib started easily within the last year or so. She had a cardioversion and then had a return of AFib about 6 months ago. So she's within 6 months of her current episode of AFib. So she fits the enrollment criteria probably of East AF quite well. And East AF was a really landmark clinical trial because it demonstrated for the first time really that rhythm control, early rhythm control in this case, in other words, rhythm control implemented in patients who are just recently diagnosed with AFib can actually reduce heart outcomes, including mortality, stroke, heart failure, which are very important outcomes. And this was really welcome finding for a lot of EPs because I think we all believed that this was true. But unfortunately, the history of AFib trials has been a bit checkered in the sense of some of the findings and some of the interpretation of the findings hasn't been ideal at times. In particular, some of the early trials of AFib rate versus rhythm control did not include heart failure as an endpoint. And if they had, maybe their results would have been somewhat different. But heart failure was not really appreciated as being a consequence of AFib at the time. Some of the early trials didn't include it. There's a famous trial, of course, the Affirm trial, which you all know. And this was interpreted in a one-liner as rate of rhythm control doesn't make any difference. There was no effect on mortality. But there's a lot of nuance to that trial. And the biggest thing that you have to know about the Affirm trial is that if you look at the number of patients who are actually in AFib at enrollment, a lot of the patients in the so-called rate control arm were actually in sinus rhythm at enrollment. You can't rate control sinus rhythm, as you know. Maybe they should have insisted on the patients being persistent AFib and actually being in AFib at the time of enrollment, perhaps. And then if you look at the very end of the trial, the number of patients who were in sinus rhythm in both arms was actually very, very similar. There was very little difference. And it was statistically the same, essentially, number of people in sinus rhythm at the end of the trial. So that's just a classic example of regression to the mean. If you apply a therapy and the therapy is not very effective, and then you compare your therapy strategy versus the control strategy, there will, of course, be no difference because you didn't really apply an effective therapy. It's not saying that the concept of the therapy is wrong, but just that you didn't apply it effectively. And in those earlier trials, which were before the days of AF ablation, included antiarrhythmic drugs only, the therapies were not that effective. So for a long time, we struggled under the burden of this weight of evidence saying that there was no difference between rate and rhythm control. But of course, if you ever read the trials and you looked into them a little bit more detail, you would appreciate that this wasn't really the correct take-home message to take from these trials. This wasn't the correct conclusion. I suppose with Affirm, you could maybe argue that perhaps the trial, it was just that the therapy was ineffective. So you could argue that perhaps the power calculations were just not correct, really, because maybe they assumed that everyone would be in AFib at the start and that everyone or most people in the rhythm control arm would be in sinus rhythm at the end. And that wasn't the case at all. Another limitation with Affirm, and I remember this era, is that at the time, people would cardiovert a patient like Miss Vena, and they would stop for warfarin after a month. They'd see the patient back in clinic a month after cardioversion. This was in the days when we only had warfarin, we didn't have DOACs. And patients in sinus rhythm, great, fantastic. You can stop your warfarin, you're back in sinus rhythm, no problem. And as we know now, of course, that's not a good idea because, of course, the patient will very likely go back into AFib at some stage and then is at risk of stroke. And we also know that the link between the actual rhythm and the stroke events is not that simple. And there's not a clear correlation, in fact, between rhythm and stroke events themselves. So, we've learned since that that's not how we currently manage AFib. So again, that's because stroke was an endpoint. That's something that kind of counted against rhythm control in those days. But the ECAF trial put that to bed, I think, with a modern, effective rhythm control strategy showing superiority over rate control strategy for people like this patient who have recently diagnosed AFib.
Awesome. Thank you so much, Dr. Cronin. That was a great way to think about the Affirm trial. I wanted to briefly touch on trying to understand symptoms in patients with AFib. I think Ms. Vena is a perfect example of a patient where their symptoms maybe weren't as clear, but she did endorse feeling much better in the 6-month period after her cardioversion. Do you see patients in clinic that sometimes don't report clear symptoms? And do you sometimes use cardioversion as a way to demonstrate that they truly were symptomatic?
Yeah, absolutely. I do. I think this is quite common, especially actually in the winter. Like, if you have cold weather, especially living in the northern states, etc., people hibernate almost for the winter, and some people don't do a lot. And then the spring comes around and they feel a bit more short of breath, or they have a little bit less exercise tolerance, and they just think, oh, just getting old. And they don't really pay much attention to it. They just kind of accept it. Kind of creeps up on them. So the symptoms can be really insidious. And I see that all the time. So I generally have a pretty low threshold, especially in patients like this, who is fairly young and not highly comorbid. I would definitely recommend a cardioversion in her case. And you can think of that as a diagnostic cardioversion. So in other words, patients in AFib, they're unclear that they really have symptoms. They say they feel okay. Generally, I would still recommend a cardioversion as a test to see do they really feel okay, because I can tell you that in my years of doing this, I would say probably 9 out of 10 patients will say that they feel better when they come back for follow-up in sinus rhythm. And you can argue maybe some of that is placebo effect, but I spend time with patients. I talk to them. I try to really elicit not just like, oh, how do you feel? Do you feel better? But like try to elicit real metrics that you can use. Like the example I said earlier about walking to the mailbox and back again, and you have to stop now, or can you do it all in one go? Something objective like that. And great majority of patients do feel better. The occasional patient doesn't feel better, and then you have to accept that they just may not derive a symptomatic benefit. And the occasional patient as well feels a bit better, but they say, I feel like 5 or 10% better, but it's not dramatic. And then you can have a reasonable conversation then and say, look, we can still pursue sinus rhythm, although realistically you're in sinus now. This is as good as you're going to feel potentially from a rhythm standpoint. Or, you could accept going back into AFib when that occurs and not do anything further about it, recognizing that maybe you feel a little bit better in sinus rhythm, but perhaps that small improvement is not worth the extra procedures and office visits and medications and so forth. The patient may say, look, I've so many other things to do, or I'm just not really interested in having a procedure done. And therefore I'll accept that I mightn't feel quite as well as I might do if I go back into AFib, and just accept that. And that's a reasonable conclusion to come to for some patients. It's all based on what the patient feels and what they feel is important for them at that time.
Perfect. Thank you so much for those wonderful comments, Dr. Cronin. Now, coming back to our patient, you mentioned that you would discuss the EAST-AF-NET trial. So after a discussion, you come to a decision about pursuing pulmonary vein isolation procedure. The patient comes in 2 weeks later to have the procedure. It goes well, and then she's able to go home the same day. How would you monitor for AFib recurrence in her post-ablation? Is there a role for monitoring in every patient?
Yeah, I think I kind of judge that very case by case. In her case, she's probably not going to be acutely aware of it if she goes back into atrial fibrillation, like right in the moment. So it's more in those patients that I may monitor more intensely. I think for patients who are quite symptomatic, when they go into AFib, they're going to know and they're going to be able to tell you, right away. Now, there is some increase in asymptomatic episodes after ablation for reasons that we're not entirely sure of. It may be due to affecting nerve endings, etc. It may be various effects on autonomic tone. But for the most part, if someone is quite symptomatic before an ablation procedure, I'm generally satisfied that they'll know if they go back into AFib. So I feel like I don't have to worry about them so much. They're going to know, they're going to call. People who are not acutely symptomatic like her, I think longer term, you do have to think about how you're going to know if they go back into AFib. The advent of things like the Apple Watch and other wearables like that, and all the other watch manufacturers, I don't want to leave people out. All the various wearables, there are many options out there nowadays, personal ECG monitors and all sorts of things that are actually very useful. And people can monitor their rhythm themselves with these devices, which I think is kind of ideal. If you have someone who has one of these devices or is willing to get one of these devices and use it, they can email me the ECGs, etc. That's very helpful. And they can monitor themselves and do an ECG once a week or more if they're up for that. Other than that, if someone doesn't have one of those kind of technologies, or they're just not very tech savvy, or they don't have the resources for those technologies, then I always ask them about their blood pressure cuff, because I think pretty much everyone should monitor their blood pressure from time to time, and especially people who have AFib and the age and comorbidities that go with that. You can also prescribe a blood pressure cuff for patients, so it can be very cost effective. And most of them have nowadays a little irregular pulse alarm or light that will flash. So you can teach your patient about how to use that, and you can prescribe a blood pressure cuff and just ask them to make sure to get one of these little irregular pulse notifications, and they can use that. And then if they detect an irregular pulse, they can come in for an ECG, or they can call, and we can manage things from there. The kind of ultimate monitoring, I suppose, is the implantable loop recorder. And I do use that in selected patients. I know the practice of that varies a bit. Some people are inclined to recommend it in a broad population of patients, and I use it more selectively, just bearing in mind that it's an invasive device. There's a cost associated with it for the remote monitoring, and there's just a general economic cost associated with the device. It's not cheap. But, they're very good. Obviously, they're excellent, and they're watching all the time. So they provide you with the best monitoring, but they're also resource intensive and expensive. But I do use that in some patients, especially in patients in whom we may have some concerns about continuing anticoagulation, in patients who have kind of good reasons not to be on anticoagulation, like previous bleeding risks, etc., and are keen to kind of come off anticoagulation and have a relatively low CHA2DS2, can be very keen that about AFib if it recurs. The evidence in that zone is in development, and we don't know the exact role of things yet, but it is a strategy that can be used and is being actively investigated. And also the other category of people in which I find this attractive is people who've had an AFib-related cardiomyopathy, where you go into AFib, their EF drops, they develop heart failure, you get them back into sinus rhythm, heart failure goes away, the EF improves back to normal, but also are not acutely aware of going into AFib when they do. That's a population in whom, and the loop recorder may be very helpful if they don't have access or ability to use a wearable kind of device, because you can be alerted as soon as they go back into AFib if that happens, and then preemptively act to get them out of it again, rather than not doing any or not knowing and them showing up in heart failure or worse.
Thanks. That's great information. Now we're going to shift gears and talk about our next patient in the CardioNerds EP clinic, Mr. Atrial Fred. This is a 55-year-old man who has paroxysmal atrial fibrillation and diet-controlled hypertension. He was diagnosed with atrial fibrillation 2 months ago after he had gone to the emergency department for palpitations, which developed soon after having several glasses of wine. He was monitored for a few hours in the emergency department and spontaneously reverted to normal sinus rhythm. He has since then occasionally felt palpitations during the day, but otherwise felt well. He takes apixaban twice a day, and he states that the most nerve-wracking part of the last few months is when he gets notifications from his watch that he's in atrial fibrillation. This has happened twice so far in the last couple of months. His primary care doctor ordered a transthoracic echocardiogram, which showed a normal left ventricular ejection fraction and normal-sized atria. How would you approach management of atrial fibrillation in this patient?
Yeah, so this is a patient with, some risk factors, certainly some opportunity for lifestyle intervention there, given that at least one of his episodes was prompted by drinking a few glasses of wine. But he has overall like a low burden of atrial fibrillation, it seems. He's got a few notifications from his watch that he's in AFib, but only 2. And he's had one episode that he went to the ED. I think the threshold for implementing rhythm control here varies on a lot of factors. I think, number one, I would counsel them that AFib, as we said earlier, it's a chronic condition, unfortunately. It tends to come back. I don't know that I really like to guarantee someone that it'll come back, because I suppose I can't tell the future, right? Like anybody else. But I do tell them that it's very, very likely to come back at some stage. And then I talk more about like, what can we do to reduce the chances of it coming back, or to delay the time that it comes back, or reduce the total number of episodes, rather than like prevent it, because it may not be possible in most patients to absolutely prevent all episodes of AFib. So I would first counsel him about lifestyle modification here. Certainly cutting back to as little as possible, and preferably zero alcohol in his case, because, once you have AFib, or an episode has been triggered by alcohol, then, that's, I think, a very clear indication for quitting the few glasses of wine completely. I do recognize that some people are not going to quit completely, but I tell them the less is better and none at all is the best. I'd also look at his hypertension, make sure that's well controlled, although trials of hypertension control, et cetera, have been kind of disappointing with respect to AFib outcomes. I'd assess his BMI, talk to him about, lifestyle. Is he sedentary? Does he exercise? Certainly encourage exercise, encourage weight loss. Those things have been shown to reduce AFib burden and episodes, or delay time to recurrence. I'd also ask him about, symptoms of sleep apnea, although again, the evidence in that field has been a bit disappointing, actually. The randomized controlled trials have not shown a convincing benefit of treating sleep apnea and AFib, but that's a whole topic into itself that I wouldn't be the best person to talk about. But I know that there's been some limitations to those trials, and the sleep specialists who are really convinced that it does help. And I've seen myself in many patients, instituting CPAP can actually help enormously with AFib burden, very objectively. So I still do assess that and talk to patients about it. And then let's see kind of what the outcome of these risk factor modification efforts is. Some people do come back to clinic and they weigh the same or more. They don't exercise, they're still drinking alcohol. Unfortunately, this is just the way it is. I think advice from your doctor to do something is strong motivation, but not everyone is going to take the advice. If the patient comes back to follow up and they're making good progress, they've lost a bit of weight, they've started exercising, not drinking any alcohol, I would say, let's kind of see how you do. Let's not necessarily add in medications right now if you feel comfortable with that, because it sounds like you're making good progress and maybe this won't come back for quite some time. On the other hand, if someone is having recurrences, maybe they're not making so much progress with their risk factor modification, I still counsel them again every visit. I give them written pointers to what they should be doing, etc. But you may want to institute an antiarrhythmic drug at that point. And at some stage, you may also want to talk to the patient about catheter ablation as well. It can be a little unsatisfactory if the patient has not made progress with risk factor modification. But at the same time, I think you also just have to be realistic and look at the advice you've given and look at what has been achieved and look into the future and to say, like, is this really going to change? Or I've tried, and is it time to kind of institute something, more definitive, like an antiarrhythmic drug or even catheter ablation, even though the patient could maybe make some more efforts, but are they just going to? If past performance was likely going to predict future performance, then they may not. And I think the number of episodes per patient before you institute rhythm control will depend a lot on different things, especially how symptomatic they are. I don't think there's any particular cutoff. Some people have AFib, they're right into the emergency room, they're highly symptomatic, it's hugely disruptive to their lives. The situation in which it occurred as well may be disruptive, like somebody may have, missed a vacation, or it may have upset their life in a big way that just makes them very, very keen never to have AFib again. And they may opt for a rhythm control strategy, very early. Other people who are maybe less symptomatic or less disturbed by it, I think you've got a little bit more time perhaps to talk through options and to try and institute some lifestyle modification, etc. So it does vary a lot patient to patient.
We appreciate you talking so much about the importance of lifestyle modification. We also will have an entire episode just on the lifestyle contributors to AFib within this series. So we're really excited to take an even deeper dive into that.
It's interesting you mentioned how much AFib causes anxiety in patients. I find this to be very true, not just from their heart rhythm standpoint, but are they going to have heart failure? Are they going to have stroke? But there's also a lot of side effects from these drugs that we use, both the rate agents and the rhythm agents. So going along that, we do have our next patient in clinic. He is a 72-year-old male with paroxysmal AFib. He's currently on Xarelto and amiodarone. He is very concerned as his golfing buddy, who also has AFib, was recently diagnosed with pulmonary fibrosis. That guy's primary care doctor told him that could have been caused by the amiodarone he had been on. Upon hearing this story on his weekend golfing, our patient has now become very worried that his amiodarone is also going to cause irreversible damage and that he too will develop pulmonary fibrosis and have to stop golfing. How should we monitor this patient while on amiodarone? And are there similar concerns with other antiarrhythmics?
Yeah, amiodarone is kind of an interesting, almost like a paradox, because it's the easiest one to start. And it's arguably the safest one to kind of reach for in a broad variety of patients in the acute setting or in the short term. But it's also the one that tends to have the highest cumulative risk of side effects, over time. So how I manage this is I assess labs, every 6 months. So I'll check TFTs, I'll check liver enzymes. I also check creatinine every 6 months. Now, what to do about the monitoring for pulmonary toxicity is a little bit less clear. Some people use a strategy of doing chest x-rays, but those are relatively insensitive to kind of early stages of pulmonary fibrosis. So, that may not be terribly useful. Some people will measure PFTs on a regular basis. That's probably a bit better, but it's unfortunately also confounded by a lot of other things. Like a lot of these patients have heart failure, and the DLCO can be affected by pulmonary edema as well as by pulmonary fibrosis. So that may not be, perfect either. There's also a lot of compliance with the testing that can be variable. The effort used during PFTs can be variable, and that can lead to results that are apparently kind of different from the last time, but they may not really be different. So I find that can raise a lot of questions, but not necessarily give you a lot of answers. It may trigger a lot of additional testing. Ideally, I suppose you do something like a high-res CT, but you really don't want to do that on a regular basis for monitoring, because that would be a very large, radiation dose cumulatively over time that someone's on amiodarone. So I don't think there's a perfect way of doing it. I think most importantly is just to listen to symptoms. If the patient is reporting, new shortness of breath, but they're still in sinus rhythm, then that's probably something you should obviously follow up on or investigate. Now, if the patient's not symptomatic, but you have ordered some PFTs and they're somewhat different from the last time, then it's kind of hard to know what to do with that. Then that'll likely trigger further investigation with high-res CT, et cetera. I feel like amiodarone lung toxicity is kind of often raised as a possible diagnosis, but it's rarely confirmed as such. It can be difficult to diagnose and difficult to distinguish from other things. One of the clues is that it usually occurs between 6 months and 2 years of taking amiodarone. So, sometimes it's raised as a possibility very, very early on after starting amiodarone, and that's actually quite unlikely. It usually occurs between about 6 months and 2 years, although it could occur later as well. But that may just suggest that there's a certain kind of dose that you need to get to, or a certain time frame you need to get to for it to become apparent, and also that there are probably, some people who may, for some reason, be susceptible to it, and then other people who are not, because if it kind of trails off after 2 years, that kind of suggests that some patients are just somehow protected from it or won't get it. With the other antiarrhythmics, there are also individual concerns with each one. They don't have this kind of myriad of weird and wonderful side effects that amiodarone can have. Flecainide is generally well tolerated. You do have to be careful of it in renal dysfunction. There are some exclusions, like people with prior MI. It's not recommended. That's been kind of extrapolated to people with structured heart disease of other kinds, which may or may not be valid. Certainly it should be avoided in significant heart failure because it's a negative inotrope as well. But in terms of side effects, it generally is very well tolerated. And the main thing we worry about is arrhythmia. We worry about atrial flutter with rapid conduction over the AV node due to slowing down of the flutter circuit by the flecainide, so that it slows down to maybe 200 beats per minute, the actual flutter circuit itself, so that therefore it can then conduct one-to-one over the AV node and cause that, what we call flecainide flutter. And then the class 3s like sotalol and dofetilide require close monitoring of renal function and QTC on ECG. So for dofetilide, for instance, I like to see patients every 3 months, or hopefully, if they also see a general cardiologist, like most patients, I'll alternate visits with their general cardiologist. So I see them every 6 months, and the general cardiologist sees them every 6 months and also checks an ECG. And, we do labs at intervals, usually just dictated by the patient's renal function and how likely it is that their creatinine will change appreciably. And you have to pay attention to, obviously, electrolytes like potassium and magnesium. Dofetilide is probably the best tolerated of antiarrhythmics, arguably, or one of the best tolerated, but the side effects, which is the one we worry about, is of course ventricular arrhythmia. This is very serious if it happens.
Awesome. Thank you so much, Dr. Cronin. So now we are wrapping up in the EP clinic. We're going to head over now to the hospitals to see inpatient consults. The first consult is from the medicine service. It's one of our long-term patients, Mrs. Atrial Fibrillation, who is back in the hospital with AFib with rapid ventricular response. Her heart rate was quite fast initially on admission, but she has been started on IV amiodarone and gotten some rate control agents as well, and her rate is now controlled to 110s. Unfortunately, this is her third admission for AFib with RVR in the past 6 months. She has previously undergone cardioversions, but always converted back to AFib. She also has orthostatic hypotension, which has limited our ability to titrate her rate control agents. She also has heart failure with reduced EF. Her most recent EF was 35 to 40%, CKD stage 3A, and hypothyroidism, which precludes most rhythm control agents. She had undergone AFib ablation about 1 year ago, but it also did not last. Her AFib returned about 2 months after the ablation. How should we proceed now?
So I think this is probably all leading towards the kind of ultimate rate control therapy, which is AV node ablation and device implant. She's back in AFib, multiple hospitalizations, difficult to control rates, and lots of reasons why it's challenging to actually use different agents like orthostatic hypotension, for instance. Her EF is reduced, so you couldn't use something like flecainide, for instance. The CKD will make digoxin, for instance, problematic to use. Hypothyroidism doesn't actually preclude the use of amiodarone because she's already on replacement and it's unlikely to kind of affect that one way or the other. But presumably if she had AFib ablation 1 year ago, went back into AFib after 2 months and, has not kind of seemed to pursue any rhythm control since then, that kind of suggests that the patient plus or minus her EP have essentially felt that wasn't a very useful maneuver and are not terribly keen to repeat it, etc. So at this stage, I think she's probably perhaps best served by considering AVJ ablation and a device implant. And that's actually, I think, a therapy that we've kind of shied away from perhaps a bit too much in the past. There is an evidence basis for it. And more recently, there was a trial showing a marked advantage for this strategy over a strategy of continued rate control. Just maybe magnitude of the benefit was a little surprising, but I think it did just flag up to us again that we should really consider this therapy in a lot of these patients. I think a lot of people, certainly myself, in years past have been kind of reluctant to destroy the AV node. It kind of feels wrong almost. You're doing something that you try hard not to do. You're doing other operations. You're actually taking out the normal conduction system. And then you're replacing the usually narrow conducting QRS complex with the paced QRS complex, which is just not a very kind of satisfying thing to do, knowing that there are problems with chronic orderly pacing in some patients leading to heart failure, et cetera. So I think it kind of has been a little underused. And I think nowadays, in the days when we have very good tools for doing bi-V pacing, and we should have very high success rates with bi-V pacing, and especially now that we have tools for doing conduction system pacing, and you can do either hip bundle pacing or left bundle branch pacing and ablate the AV node and actually still have the patient have a pretty physiologic QRS complex. I think, that has taken away some of this reluctance. And I think it's a strategy that probably is implemented maybe a little bit more than it was in the past. And I think that's probably right too. I think that's the right way to go in some of these cases. So I must say in this kind of case, I'm a fan of doing that. I know she's, heart failure with reduced ejection fraction with an EF of 35 to 40%. So the exact type of device here is a little bit up for debate. I think depends on the cause of her heart failure, et cetera. And, some of the other clinical details, but in this patient for sure, I would want to do physiologic pacing. So the strongest evidence basis here is for bi-V pacing. So, standard biventricular pacing, but although the evidence basis is not quite as robust, I think probably 9.9 out of 10 EPs will probably tell you that they would feel that left bundle pacing or his bundle pacing should be, just as good. And the other 1 out of 10 EP will probably tell you it's better. So I think we can certainly choose between bi-V pacing or left bundle pacing, his bundle pacing in this patient, along with the patient according to their preferences, but all are reasonable options.
Yes, I agree with you. I've certainly seen cases where we were, very hesitant to do AV node ablation for the reasons you mentioned, and you sort of pushed it off and delayed it. And then when we finally did offer that to the patient, they felt a lot better and really did well clinically. So it's a great option to be able to offer these patients who are really at the end stage of their atrial fibrillation. Our next consult is from our colleagues in cardiovascular surgery. They have a patient who's currently admitted who needs coronary artery bypass surgery for obstructive coronary artery disease. He also has a history of long-standing persistent atrial fibrillation for the past 3 years. The reason for consult is to ask for advice about management of atrial fibrillation in the postoperative period. What advice do you typically offer in these cases?
Yeah, I think this is an area where I think there's a little bit less kind of certainty as to what to do. So, one question, I think there are probably three questions here that I would think about. One is, should the patient have a maze procedure? He's going for coronary artery bypass surgery, adding in a maze procedure to that procedure with a surgeon who's very facile with the procedure doesn't add a ton of time and can kind of be done there and then. Doesn't add a lot of time to the operation and hopefully could be accomplished. And will it be useful to the patient or not is the question. So I think that would depend on the details a lot. The patient's symptoms. Do we know how symptomatic is an AFib? Has he ever had the diagnostic cardioversion that we talked about before? Does he have heart failure? In which case maintaining sinus rhythm certainly should help him. So I think some of those details would go into that. But I think we don't have a very clear understanding of exactly who benefits from an add-on maze in the setting of surgery, like we do perhaps for early rhythm control in AFib. But if he kind of fits the picture, if we can extrapolate from the non-surgical data, there certainly is going to be a proportion of population here who are going to benefit from concomitant surgical AF ablation. So that I think is something that definitely should be considered. Also, I think it depends a little bit on the surgeon, themselves and what their level of familiarity is with maze procedure and what their results have been, because that can obviously influence whether to your kind of threshold for recommending it or not. I think the next question is, what about the left atrial appendage? And I think it's pretty clear that in this patient, I would definitely recommend left atrial appendage closure at the time of surgery. There's accumulated data now that suggests that this is beneficial and reduces stroke risk. And, that certainly makes a lot of sense. It makes total sense biologically, which is the first step for any hypothesis. And it's also been shown in the LAOS-3 trial more recently that this is beneficial with continued anticoagulation. So I would recommend that. And it's something that the surgeon can achieve with the tools that are available now very readily. In the past, sometimes it's been criticized that a lot of these left atrial appendage closures, maybe 40% or so, were not complete. But I think we now have much better tools to enable the surgeon to accomplish this. So I recommend that. And then, the other question, I suppose, is regardless of what's done, how to manage the AFib and the perioperative period, you'll often see people reaching for amiodarone, postoperatively. People have studied starting amiodarone preoperatively in order to prevent post-op AFib. And just an interesting trial or point here, it was a trial, I think, by Mark Ilanov from Cleveland Clinic. It's in New England Journal. It was where they took patients, mightn't fit this patient exactly, but they took patients who had undergone cardiac surgery and had experienced post-op AFib, and they randomized them to rhythm control or, rate control, no rhythm control during the hospital stay. So in other words, a strategy of like cardioverting the patient before they got out of the hospital versus just rate controlling them and kind of seeing how it did. And actually the number of patients in sinus rhythm at follow-up was no different between groups. This is obviously in patients who, were tolerating the AFib okay, were not highly symptomatic, were hemodynamically stable, etc. So I think that was actually quite a nice trial. And it shows that you can be a little bit relaxed with post-op AFib, in some cases, in the sense that you don't necessarily have to get the patient into sinus rhythm before they leave the hospital. It is okay and actually probably results in a shorter length of stay and fewer procedures, etc. If they're not symptomatic and they're stable, etc. And the AFib is new, to just ensure they're adequately rate controlled, to see them back and follow up. And, many or most of these patients will actually be back in sinus rhythm.
Wow. I feel like we have covered a whole lot of ground today on the management of chronic atrial fibrillation. Thank you so much, Dr. Cronin, for shedding light on this topic and helping highlight some of the key developments throughout the trials and in the guidelines to help us better manage this very complicated patient population. Before we close, I do want to ask you, where do you think the biggest knowledge gap still lies in AFib management?
Yeah, there are so many. How to pick just one? I think there really are quite a few. But I suppose one area that there were two big trials published in after the 2023 guideline came out. Of course, we knew these trials were coming, but you have to publish a guideline sometimes. You can't like waiting for the next trial, right? Because you'll never stop waiting. Knowing that there was these two trials, big trials coming out, we had to kind of just assess the literature where it was and just leave it at that, and then leave the analysis of the NOAA trial and the Artesia trial to the next group to take up these guidelines. But that was a really interesting time. I think there were two big trials that were published on device detected AFib. And this is a really common clinical question, and it comes up, and there are people who've studied this for decades, and we still don't know all of the nuances and all the details. So I'm going to say there's definitely lots of analysis yet to be done on device-detected AFib, trying to define, what's the burden that merits anticoagulation, what's the relationship between symptom number and symptom duration and so forth. What's the duration of AFib that you're concerned about that raises stroke risk, et cetera. All kind of confounded and complicated by the fact that pretty consistently we found that the link between individual AFib episodes and stroke is not really that straightforward. And that's just taking it back to the patient. That's always something I try to emphasize to patients, that they're anxious, they're concerned about having a stroke. I always try to reassure them, look, you're in AFib right now. That does not mean you're going to have a stroke. You're at no more risk of having a stroke right now being in AFib than you were last week when you were in sinus rhythm. And the treatment for it is anticoagulation. And you don't have to be really concerned that you could have a stroke at any moment. You kind of get to the hospital right away. And sometimes you have to kind of broach with the patient the idea that, look, if you know you're in AFib, but you're feeling okay, and you know from past experience that it'll go away on its own because you're paroxysmal, et cetera, you can consider just waiting it out at home, just taking it easy. It'll stop. It always has in the past, et cetera. And kind of trying to make sure that people are not kind of afraid of things that they don't have to be afraid of, I think is an important part of the management.
Yes, thank you very much. Hopefully there are some future electrophysiologists listening out there who will help us answer some of these unresolved questions about how to manage atrial fibrillation. I think one of the biggest takeaways we got from you is how individualized AFib management is for our patients in applying the evidence that's out there, but also taking the individual patient into account. Before we close out, we have a question that we ask everyone on this podcast, and that is, Dr. Cronin, what makes your heart flutter about managing atrial fibrillation?
I'm going to switch to the device side of EP and say that one really kind of niche, but really, really interesting development related to AFib is the increasing interest in physiologic atrial pacing and the ability of that to reduce AF burden or AF episodes. First shown in a randomized controlled trial by Steve Bylin, years ago, I think year 2000 or so. It's been around for a long time, but it's one of those things that's kind of like hasn't received as much attention. And now, interest is growing in it thanks to some more recent work on it. So that's a really fascinating, I think, angle on AF management that really makes my heart flutter.
Thank you again, Dr. Cronin, so much. We definitely appreciate you sharing your expertise on this. I also want to thank everybody else who helped contribute to it podcast today. I know I learned a lot, and I feel like my fellow cardio nerds out there will also learn a lot from this information. So thank you, everybody.
Thanks for having me.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Bhavya Shah. I'm an intern in the CardioNerds Academy House, Eindhoven, and a fourth-year medical student at Rowan Virtue School of Osteopathic Medicine. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.